I'm one of about 7 that we have on staff here at Mayo Clinic that cover all the inpatient units and provide consultation for clinical questions to outpatient and CL services in different areas. So we're always around. You'll learn our pager numbers. But I'm also around mostly 2 West, Herman Home, which is residential treatment, and in our Clozapine clinic, which I guess is a nice segue to get into the topic that we're going to cover today, which is Clozapine and the Risk Evaluation Mitigation Strategy Program. I'm going to see if I can share my screen. Usually I do this live, so I don't have a PowerPoint, so hopefully it's not too droning, but we'll get through a little bit of information. And from my understanding, this year you guys will all register with the Clozapine REMS program. And so that'll get you set up for inpatient and then moving on into the outpatient in your subsequent years here. Just by a show of hands, because I can see some of you, how many people have heard of the REMS program for Clozapine? Yeah, everybody, or most people. So here we need to essentially assess Clozapine for the risk of severe neutropenia, which is greatest in the earliest time when you start the medication. And so the FDA says that providers, along with conjunction with pharmacists, can help enter in a patient's ANC into this centralized database that essentially tracks patient's ANC over time. It also then will calculate when a patient goes from weekly monitoring when you first start the medication to the every other week monitoring to the monthly monitoring, which is the usual progression of monitoring the medication. If somebody does well and their counts maintain stability. Clozapine used to not have a centralized program that you can put in ANC values, and so depending on the manufacturer of Clozapine, you had to call that manufacturer and enter it into their program. So there were like 5 different programs that you had to know what brand of Clozapine they were taking, and it really was a big mess. The other issue was that a lot of the programs had different variances that allowed for people to continue Clozapine if they developed severe neutropenia. So for example, somebody that's been on Clozapine for 20 years, gets cancer, goes on chemotherapy, and then develops, an ANC count of 0, you likely know that's not from the Clozapine. But based on some of those programs, there was a rule that said you cannot re-challenge a patient at any point if their ANC dropped below a certain value. And so this new program allows for a little bit of flexibility and more clinical decision making. So let's see if I can share my screen. All right. So I won't make these huge just so, but everybody I can see nods, people can see my screen. Okay, perfect. So I'm going to talk probably for about 30 to 40 minutes, but I'm not going to get too much into the clinical aspects of Clozapine, but I'll tie some of these in because coming in, you'll be on call, you might have programs, it might be somebody admitted to medical where you need to, authorize continuation of Clozapine. So there are some processes that are specific to Mayo that we'll cover. And there's also some helpful information that we'll kind of just cover. I believe I'm coming back in October to talk to you guys, do some more in-depth talks of pharmacology related to Clozapine and antipsychotics. So we'll just kind of do some tip of the iceberg stuff with Clozapine, but really focus on some of the information that'll help you get registered for the REMS program. As you go to the REMS website, which you can see here, clozapinerems.com. Has anybody been here yet? I don't know if anybody's talked to you guys about this yet. But you can go here, start your registration process, and there's an 11-question quiz that's in the prescriber certification information, this Clozapine and Risk of Neutropenia, a guide for healthcare providers. It provides all the information you'll need to know to answer that 11-question quiz. Also, if you look at my PowerPoint, there are some points that have asterisks, and those would also be important to note to help you pass that. And so I'll send this PowerPoint out to you guys as well to help you kind of expedite some of the crucial points that you need to answer for the REMS certification quiz. So clozapine, some of you may know it was the first second-generation antipsychotic that was approved in the United States right around 1989. So it was actually available in Europe first. While it was available in Europe, in the United States, clozapine was undergoing phase 2 and phase 3 trials to come to market. But right around the 70s into the early 80s, use in Europe was halted because of infection and deaths related to infection secondary to severe neutropenia. So it was pulled from the market in Europe, and in the United States, the FDA said, oh, we're going to put a pause on all of this. And so clozapine, that was having these clinical trials was put on pause, essentially, and not accessible for patients. As the 80s progressed, there was recognition that clozapine actually helped quite a few number of patients. And so there was a compassionate use program allowed that said if people were already enrolled in that trial, they could continue the clozapine. And so that continued. And then, other psychiatrists were like, why can't I have the benefit of clozapine for my patients? And so the use sort of expanded. So much so that John Kane, who's sort of the father of clozapine therapy, they say, went to the FDA and sort of leveraged, how can we get clozapine to market? And so the FDA came back and said, you can study clozapine and continue with some of the phase 3 trials, but it has to be a superiority trial. And it has to be in a patient population where the benefits would outweigh the risks. And they determined that that was a treatment-resistant population. So that's a little bit of history of how clozapine came to market specifically for treatment-resistant schizophrenia. Other notable trials that, through your first and second year, you may just want to pull because it's just good information. The Intercept Trial, this is a trial looking at clozapine versus olanzapine for reductions of suicidal behavior in patients with schizophrenia and schizoaffective disorder. While the results of this are somewhat maybe debatable, it actually gained an FDA approval for this because of the Intercept Trial. So in addition to being FDA approved for treatment-resistant schizophrenia, it also has this reduction of suicidal behaviors in patients with schizophrenia and schizoaffective disorder. Other trials, one that strikes my mind is the PHIN-11 that also shows that clozapine overall has lower mortality risks as compared to other antipsychotics. This study is now over 10 years old, and I think they did a replication of this that showed similar benefits. So there are other trials out there, showing the benefits of clozapine still. And of course, a handful of economic studies just showing benefits of clozapine that I won't necessarily get into today. But with all of the benefits of clozapine, there's the other side of it. So all of the reason why people don't prescribe clozapine or why patients, might fear clozapine, and really why in the United States clozapine is underutilized. If you look at developing countries in Europe and even countries in Asia, the use of clozapine in patients that would be eligible is about 20% estimated. And in the United States, there's very few states that have about a 10% use rate of clozapine, with some of those states having very low rates. And so the experts out there say that, we should aim for this 10% of clozapine use, which most states don't get to. And there's a lot of barriers to clozapine use. So there's the blood monitoring that we know. There's tons of boxed warnings that we'll talk about here, and just side effects. From a metabolic standpoint, it's one of the worst up there with olanzapine. So the weight gain, is usually not preferable to patients. And so there are side effects that, as prescribers working with patients, we have to navigate. So with all the benefits, like I said, there are side effects. The side effects that have a little asterisk here and are bolded are the boxed warnings of clozapine. So as you become more familiar with clozapine and start prescribing clozapine, really ingrain these into your memory. So the severe neutropenia and the reason for the REMS program, there's a boxed warning for seizures, so it runs about 3 to 5% at usual therapeutic doses, which is a pretty good percentage rate as compared to other antipsychotics and really for any medication. Myocarditis and cardiomyopathy has a boxed warning. Hypotension, and those last two I'll specifically talk about because as related to patients admitted to the hospital, there can be some potentially fatal outcomes that happen. Metabolic side effects, and then a whole slew of other ones as well. Aspiration pneumonia because of the sialuria associated with clozapine, so hypersalivation. Clozapine is also the most constipating, so it's very anticholinergic, and so the risk for ileus bowel perforation certainly exists. And so those are things to be mindful of as you're increasing clozapine to monitor for bowel movements and bowel status. So why a lot of these side effects exist can be explained by the receptor binding profile. So clozapine, as compared to other antipsychotics, is extremely anticholinergic, so affinity for the M1 receptor, significant hypotension with affinity for the alpha-1 receptor, and then sedative and weight gain effects as it relates to blocking H1 receptors. And so as compared to the others, that's why you see some of these side effects more predominantly with clozapine as compared to others. So I'm going to throw a few cases in throughout here. These are cases that I've seen either in my training, other institutions, or here. So there was a 50-year-old gentleman who's transferred from an outside hospital with complaints of abdominal pain and distension. Essentially, he had distension of the large bowel, impaction ileus, and diagnosed with megacolon abdominal compartment syndrome, and so ended up losing a large component of his gut. But the thought being he was on a high dose of clozapine in conjunction also with some other anticholinergics that can compound constipation risks or gastrointestinal hypomotility, and so just one of the more severe potential side effects from clozapine. So this concept of clozapine-induced gastrointestinal hypomotility is just something to keep in your mind as you're prescribing clozapine or have patients that are already on clozapine. Up to 60% of patients may have mild to moderate constipation, but our goal really is to prevent that to develop into these more serious cases where the mortality rates up to close to 30% if they develop. All right, so we'll get a little bit now into the REMS program. Again, if there's an asterisk, it's an important component for that REMS certification. And so the monitoring of clozapine for the REMS program is the ANC. In the old program, you had to report WBCs and the absolute neutrophil count, but for REMS, if you enter it, you only need the ANC. So when you start clozapine in a patient who has never been on it, they're going to get weekly CBC with differentials for weekly for 6 months. And after 6 months, if there's no drop in those counts, then they can go to every other week for 6 to 12 months. And then at 12 months, they can go to every 4-week monitoring indefinitely while they're on clozapine. And so they need to get that monitoring done, or typically the pharmacy won't dispense the clozapine. We are in the time of COVID, and so things are a little bit different. So I'll just throw that out there. It may not apply maybe to you, because if you have inpatients, we have lab access here, but for some of the people with following outpatients, there's a little bit of leniency, but that's going to be based on pharmacy to pharmacy. Our pharmacies here at Mayo Clinic do allow a little bit of that leniency. So there might be a situation where patient can't get to a lab, or they're in a 14-day quarantine. There are some leniency to be able to get the clozapine. And really, in this monitoring, we're looking for severe neutropenia, which is defined as less than 500 cells per microliter. The peak incidence is around 1 month. So as you're starting your inpatient tours, you'll end up seeing these patients with new clozapine starts. And so really being mindful that those are ordered. You're lucky here that the pharmacists are allowed to order the ANCs for you. So it's something that's kind of done behind the scenes in terms of the ordering, but they'll work closely with you to make sure that the ANC is done and that it's reported to REMS for the patient. The baseline overall risk of the neutropenia is about 1.3%, and you can see that risk significantly drops after 6 and even 12 months. So much so that, it becomes pretty similar risk to other antipsychotics, mostly some of the older first generation agents. And so if you really dig into the literature, you can find some experts arguing that, we probably don't need to do monthly indefinitely. There's some thought that it could be expanded. In the Netherlands, they allow for certain stable individuals to be quarterly. Not quite here yet. So the REMS program does say that you need it every 28 days with some certain exceptions pertaining to COVID. So again, that website's listed in the PowerPoint here, and I'll send that out. I'm not going to get into all the details about the minutia of REMS, but essentially the patient needs to be registered, the pharmacy needs to be registered, and the prescriber needs to be registered. So all three of those components need to be tied to this REMS website in order for Clozapine to be dispensed. There are some aspects of what a pharmacy needs to do, so they'll verify that the prescriber is certified with REMS when they go to dispense. And then they have to make sure that the ANC is within acceptable range. A lot of it's now automatic. So essentially REMS is tied to their adjudication system, and it'll automatically just dispense. Somehow there's a way where it might get held up if there's not a lab or there's not a prescriber tied to REMS. Those aren't things you necessarily need to know, but there's a question on that for the certification. So highlights for when starting Clozapine, as it both pertains to inpatient and outpatient. As a prescriber, one of the steps is also to see if a patient has benign ethnic neutropenia. So these would be individuals that have low baseline ANCs, but aren't at higher risk for infection. And so this would predominantly be African American, those with African descent, or certain Middle Eastern populations where the incidence of benign ethnic neutropenia is about 25 to 50%. So that's something to be aware if you're like, oh, this is low, I can't start Clozapine based on this. Is it that they have benign ethnic neutropenia? Why that's important is there's actually a separate algorithm for patients with benign ethnic neutropenia. So when you go to register your patient, it's going to ask you, do they have benign ethnic neutropenia? And they actually have lower thresholds for when you need to increase monitoring frequency or stop the medication because of low counts. And so as I can scroll down here, if somebody has moderate neutropenia defined by 500 to 999 cells per microliter, for benign ethnic neutropenia, you can continue. But for the general population, you would interrupt if it were suspected to be due to Clozapine, increase your monitoring to 3 times weekly or daily, based on the ANC, and then resume once the ANC normalizes. So that's one component of why they ask specifically, does a patient have benign ethnic neutropenia? Like I said, you'll enroll the patient into REMS. You'll discuss the risks of neutropenia and other boxed warnings or side effects with patients and caregiver. This is all part of the attestation when you go to register for the REMS program. And then you'll need to have a baseline ANC to enter, and that can be within 1 week time period. So, a lot of times somebody might be admitted, you get labs on admission, but it's, by the time they get on a medication, it doesn't work. You consider Clozapine, you might need to repeat that ANC. And so then there's different thresholds for how low that can be to start Clozapine. Again, based on benign ethnic neutropenia categorization or general population within the REMS program. In general, there's no true contraindications the Clozapine in the package insert described, except for a true hypersensitivity type reaction. But there are some clinical considerations based on those boxed warnings. So obviously, if somebody has a seizure history that's not well controlled, and they're having frequent seizures, you might pause or get neuro involved to optimize their anti-epileptics or something along those lines. If adherence is poor, you hear, oh, well, they may not go to labs or get labs. Clozapine actually might make them well enough to have insight that, hey, I need to go get labs or be adherent. So try not to use that as a reason not to use clozapine. Now, certainly if somebody's been on clozapine and they have a history of stopping and starting it, that potentially can be dangerous. And so there's some of those considerations, but in general, not necessarily a true contraindication. Access to labs is another important piece. So if they're in rural somewhere and they just physically can't get to a lab, you might see if there are, labs that can drive to the home. There are some services that do that specifically for clozapine, or is there another way? But if there's a barrier to lab services, then they wouldn't be able to do that either. And then other past medical history or disease states that could compound risks, or just clinical considerations, but not necessarily true contraindications. So just some things I think about on new starts. So, especially if you're on call and you get a nurse on the unit saying, patient's having, they're not feeling well, they look feverish and they just started clozapine. One of those things, in addition to just, do they have an infection with low ANC or something like that, but also the risk of myocarditis, which is greatest within the 3 to 8 week time period of exposure, and then it starts to drop off after that. And so things like chest pain, shortness of breath, tachycardia should all be sort of clues to think, should I grab an EKG, troponin, CRP? But with myocarditis, some of those signs and symptoms are non-specific. So like abdominal pain and not just and looking just unwell or not feeling great, those are things that shouldn't be ignored either. There's a lot of case reports out there, kind of saying patient just didn't have any specific, cardiac symptoms, but, ended up then developing myocarditis. And there were some early indicators potentially that something was going awry. There are a set of guidelines out there by the Australians. They're actually pretty rigorous in their monitoring for myocarditis. So in the first 4 weeks of treatment, they'll actually get EKGs, tropes, and CRP weekly. We don't necessarily do that here. It's not a standard practice. But again, if there's signs or symptoms or there's concern, have a low threshold for getting CRP, tropes, and EKG. Other things I think about, sialorrhea is pretty unique to clozapine, so increased salivation, which can be bothersome for patients. If you want to manage that, think about some agents that work locally, so atropine drops that you would put under the tongue. Systemic anticholinergics can be used, but they can compound that constipation risk. And there's some others, but that might be something to think about. Clozapine is also associated with pneumonia and aspiration pneumonia, and so one thought is untreated sialorrhea might contribute to that. If you're going to use sublingual atropine, make sure your order says sublingual in bold with stars somewhere around that. There's been at least one kind of administration error where actually a patient got that in the eyes, which was not ideal. So when you're ordering it, also just make sure that the right route is put there within the Epic system. I can't remember right now what it defaults to, but just make sure the route's there. Some drug interactions with clozapine. The big one you might be already familiar with is smoking. So smoking induces 1A2. So if they come into the hospital and they were already on clozapine and they stop smoking, then their clozapine levels may increase. It's not dramatically increased over a day. Typically takes about 5 days to a week to start seeing some of that reversal, but that's something to think about too. Or if you get them a patient stabilized on a dose of clozapine inpatient, and then they go out to the community and start smoking again, their clozapine levels are going to drop. So it's just a good reminder for follow-up and dose adjustments as needed. There's 2 medications that can be potentially fatal with clozapine, and that's Luvox or fluvoxamine, and then ciprofloxacin. These are 1A2 strong inhibitors that can significantly increase clozapine levels. So when you see those two, just kind of have a double thought of kind of what's going on there. There's some, okay, I'll mention it, I guess. There's some literature looking at augmenting low-dose fluvoxamine with low-dose clozapine to change the way clozapine's metabolized, but it has to be done very carefully, and it's not something that's frequently done. So if you see the combination, you probably just want to double check that or ask. All right. So that's for new starts. So for continuing Clozapine, there are a few things that need to be done, or you may be asked to do if you're on call or something like that. So when a patient comes to the hospital, whether it's in Genros or to a medical unit, the pharmacist will need to verify the dose, and then the pharmacist also needs to verify if the patient's been adherent to the medication. And so if you remember, I mentioned Clozapine has a boxed warning for severe hypotension. Within the package insert, it says if somebody's been off of Clozapine for more than 2 days, the medication has to be retitrated and started at a dose of 25 milligrams. So even if they were at 400 milligrams, you'd want to start that back at 25 milligrams and then titrate that back to their original home dose slowly. And that's because of the profound severe hypotension effects that Clozapine can have. Probably if there's any side effect that I'm most concerned about, it's this kind of stopping and then starting a full home dose again, just because of those hypotension effects. You know, the constipation can be severe, but usually you can monitor and manage that. But this is one that can be, you know, potentially life-threatening. And I think, yeah, I have a few cases coming up here soon. And then smoking status might be another thing. So patients admitted to medical, what is going to happen? So the pharmacist would review the medication list, and they would contact a psychiatry pharmacist. We would then make sure that the patient is enrolled in REMS, to make sure that it wasn't, you know, a med history error, and instead of, you know, clonazepam written down, Clozapine was written down or something like that. And so we would make sure that they're in the system, make sure that their ANC is up to date and ordered if needed. We would have the pharmacist working with that patient, verify their dose. So a MAR from a group home, family member, directly the patient, depending on the circumstance, if they're able to do that. And then we would actually contact the CL service, or after hours it would be the on-call. And the pharmacist would say, you know, we had to have this patient admitted to medical. We confirmed their dose. We confirmed that they were adherent to their medication. Let you know their smoking status, and then essentially you would go into that patient chart, write a miss note just to say pharmacist verified dose and adherence. The primary service can continue Clozapine. And that's just a safety check. It's one extra layer, as opposed to just the primary medical service going ahead and to start, you know, Clozapine without having verified that information. Things are a little bit easier in Genros because you'll be maybe admitting the patient or seeing the patient, so you can get that information directly, you know, and so that's a little bit easier. But really, from the medical side, there's a little bit more complexity to that. So there's a few cases highlighting that. 63-year-old, his home list included Haldol and Clozapine. His home dose of Clozapine was restarted 350 milligrams, had a rapid response team called to his room, being found unresponsive and hypotension. We actually ended up finding out that Clozapine was discontinued at an outside facility 2 weeks prior. And so Clozapine had just gotten left on his med list from a prior admission. This was a case that his home medications, which include Clozapine 450 milligrams, and he ended up in cardiac arrest with severe hypotension. They did get a serum level, which ended up showing that he probably wasn't taking his Clozapine. And so if there's anything to learn from this, is that when you're writing for Clozapine for continuation, if the patient seems unreliable, if you can't confirm, just wait until the next day. There's some risks obviously of holding Clozapine, but if they have been taking it, you have 12 hours. It's not going to be a huge issue probably. But if you restart that and they hadn't been taking, there can be some significant consequences there. Clozapine levels, there's a few slides on here, but just kind of rule of thumb, they don't, they batch the labs, so they only do them certain days of the week. So if you get a Clozapine level, it's not going to come back that same day or even within a few hours. So you can't necessarily stat a Clozapine level. Consultants can call the mass spec lab and have it expedited so they can set it up, but the assay takes a long time to set up, so it might even be 8 hours before the result comes back. And so, you know, there's one case where this also happened. The patient said they were taking it, the group home said they were taking it, but they're also on warfarin and their INR was 1.3. And so that was an indicator maybe that they weren't adherent to other medications. And so, you know, if they're on lithium or something else that has a serum level that you're obtaining anyways, you know, kind of use that maybe as a marker, but, you know, address that as in a case-by-case basis. So again, really just to highlight that, confirm adherence, probably one of the most important things here. And when in doubt, just, you know, start a starting dose and, you know, retitrate or return to the home dose if you get more collateral. Smoking I already talked about, so I'll just leave these slides here as FYI. Same with sort of the therapeutic drug monitoring. Really, again, just to highlight that it's not a send out anymore. It's actually, they do it in-house, but they batch it, but it does take a few days to come back. Clozapine levels, don't necessarily need to cover it here, but kind of rule of thumb, if you just want to ballpark, about 100 milligrams should be about 100. So, you know, if somebody were taking 300, you might expect their level to be about 300. It's going to differ if they have drug interactions or if they're a smoker. Women tend to metabolize clozapine a little bit more slowly, so they're going to be on the higher end of that. In terms of what you'll see in the lab, this is an old screenshot from our old system, but essentially you'll get a clozapine level, a norclozapine level, and a total. When you want to assess for kind of what is a therapeutic response, it's just the clozapine level by itself, and you're looking for at least 350 nanograms per milliliter. As you start to increase with that clozapine level, you have risk of side effects, and greater than 1,000, there's potential for toxicity. But again, with any sort of drug level, treat the patient, not the number. There are treatment-resistant patients that, you know, do tolerate the level of 1,000 and they do just fine and they do well with that. So just because something comes back high, you know, it doesn't necessarily mean you need to reduce the dose or that there's toxicity. And always think about lab error too. So we actually had a patient whose level was greater than 1,000, and we're like, oh, you know, what's going on? But he was doing fine. He didn't have any side effects. We ended up repeating it, and it was closer to 250 or something around there. So there is always the potential for lab error for that not to be accurate. So just repeat it if clinically no dose adjustments are needed and you want that level. Not continuing clozapine, there's a few risks, but again, always think about the safety of restarting. You can have a withdrawal catatonia, there's cholinergic rebound, so you can get things like upset stomach, diarrhea, nausea, vomiting, emergent EPS type symptoms, and return of rapid symptoms, so psychosis. So just some potential risks there. This slide I already talked about. This is just an overview again of what to do if somebody's on the medical service and you get a call. Pharmacists, if they call you, they'll walk you through that too. So you know, you can just refer to this slide or kind of just ask the pharmacist, you know, what's typically done until you kind of learn the process. And then the last few slides here, again, just note the asterisks. There's some questions as it relates to benign ethnic neutropenia, and then some of the guidance on when you need to follow that REMS table for what to do if somebody's labs drop. And that's sort of my intro to clozapine and the REMS program. So with that, like I said, I'll send these slides out. Does anybody have questions? All right. Looks like the Chiefs aren't here. Oh, there we go.
We're here.
Hello. I knew you were there. Yeah, just hiding.
Yeah.
So no questions. Again, I'll send the slides out for you guys to distribute. And that is all I have, I think.
Cool. Thank you, John.